Good afternoon and a very warm welcome to our viewers to this Master Series episode. Today is a special one to commemorate the World Brain Tumor Day, which is tomorrow. Today's topic of discussion is treatable neurometabolic disorders in children. Now, we have with us Dr. Vykuntaraju with here. He's a professor of pediatric neurology at Indira Gandhi Institute of Child Health in Bangalore. He's done his pediatric neurology DM from AIMS New Delhi and has academic activities which consist of around 160 PubMed index publications, 60 in other peer-reviewed journals, and 310 abstracts at conferences. He's also written a textbook on cerebral palsy and 25 chapters in other textbooks. It is an absolute pleasure to have you with us here, sir. Over to you.
Thank you. So today I'll be talking on some of the neurometabolic disorders that are commonly seen in children. So some of them are treatable. So this is the outline of my introduction. So there are many metabolic disorders, but a few of them are treatable. The most common metabolic disorders that comes to pediatric age group are aminoacidopathies and also other metabolic disorder like urea-cycle disorder. These are two common conditions that can be treatable. And as you know that there are more than 500 subtypes of neurometabolic disorders. Out of this, at least 1/4 of them can be treatable with the various modalities like vitamins and also some special diet, formula diets. So this is a list of the disorders that can be treated in children if you recognize early. Some of the examples are phenylketonuria, maple syrup urine disease, and homocysteine metabolic disorders. And in other categories like urea-cycle disorder, some of them are treatable. So I will be going case by case basis, and I'm giving some of the examples how they are present in children. This is another list that shows that what is exactly how common is this disorder, subcategories of disorders, what is the modalities of treatment. If you consider the most common disease is phenylketonuria, it is seen almost 1 in 10,000. That varies based on where exactly you are practicing. Maybe it may be less common in India compared to other countries. But in India itself, it is more common in South India compared to Northern India. So the disease varies prevalence based on where exactly you are practicing. And the more treatment in this children is basically the phenylalanine restricted diet, sometimes medication also. These are some of the treatment options and what exactly the reason for these disorders and how common is these disorders. This is a table. I'm not going to detail each line. So to classify clinically how these children present, these children can present in many ways. The most common presentation is they will present in the first month of life. Usually they will present to neonatal intensive care units. The other mode of presentation, the older children, they can present to pediatric intensive care units. Usually neonate will call less than 4 weeks. After that, you will take pediatric children. And sometimes they can come to an outpatient department or those who are slowly progressive disorder. Those coming to NICU, that is in the less than 4 weeks of life, they are very severe conditions. And unless we don't diagnose early, and the chance of survival is very less. So you should be very cautious and you should be eye vigilant on these children and you should be recognized early and should be treatment very rapidly. Other group like mild forms, they can present the older age group. Again, they can present with acute problem like coma or seizures or art sensorium. When there is a infection, like whenever there is some infection, like viral infection, normally children they will recover. But in this type of children, following infection, they will deteriorate fast and they will go to coma and they may not respond. That time they may go to a pediatric intensive care unit. Some of the other disorders, they're very slowly progressive disorders, like storage disorders. They will not present to the emergency room. They will present to the OPD, outpatient department, usually seen by neurologists. They will present with the development, that is intellectual disability, or some other features like seizures. So these are 3 modes of presentation of these metabolic disorders in children. So the most commonly, as I told, they can present to the ICU department with comatose children. So in India, most of the times, whenever a child comes to coma, you'll think of a viral fever like brain fever. But there is some point that will differentiate whether the coma is because of brain fever or it can be due to neurometabolic disorders. In brain fever, usually they'll get with the fever and usually the features like seizures on one side of the body and usually they'll get signs of meningeal irritation, what we will call. And also the MRI, sometimes the fluid will take CSF test that will give important clue that it is a brain fever rather than a metabolic disorder. In the absence of these features, you will consider the encephalopathy. Encephalopathy, because of metabolic causes, So this condition should be considered whenever there is high suspicion, especially the previous death in the family, or those parents are married in same region, or consanguineous marriage, what you call in the same family. If they marry, the chance of getting these metabolic disorders are very high. And these children, other tests like CSF analysis will be normal. Sometimes other tests like lactate, TMS, what we will call, those tests use important clue for suspected neurometabolic disorder to be managed and diagnosed, and treatment should be started. Coming to some specific commonly seen condition in children is, this is one of the case. This child presented around 45 days of life with complaints of vomiting, and also child has a complaining of excessive crying and not able to consolable, not able to sleep properly for 2 days. And is coming to other history like his birth history, everything was normal. And examination shows the stiffness of limbs was noted. And the routine metabolic sepsis workup that is commonly in India is infection, where infection workup was normal, and including some basic metabolic tests like lactate, ammonia, ABG also was normal. And child noted that one episode of low sugar level noted, and the ketone bodies you will see usually commonly in children, that was positive. So based on this, I will proceed further, like further tests are MRI brain. In this MRI brain, you can see that lot of signal changes in the posterior fossa, especially cerebellum and brainstem. It is suggestive specific neurometabolic disorder, that is maple syrup urine disease. This should be suspected very happily because specific treatment is available, and if you don't start, usually they will die within few days of onset of the disease. So other tests to confirm this disease is TMS. So this test again shows that the increased amino acid like alanine, valine, isoleucine, that is suggestive of our suspected diagnosed maple syrup urine disease. So basically, other photographs are the different child shown again the MRI brain showing extensive signal changes in the posterior fossa of the brain. There are a few more children. They present mild form later childhood with the infantile spasm. This child presents a specific type of epilepsy that is difficult to control, and this is the same type disease. It's showing different type of MRI pictures. So even though that this is the same, they will present in different ways and based on different age of onset and also severity. These children basically should be diagnosed early, because treatment with some vitamin like thiamine with high doses is very useful. And also special formula diet is available. If you start early, the outcome will be very good. And also diagnosis is also important to give antenatal diagnosis for next baby also. And the recurrence will be more than 25%. Coming to the next common scenario, what you will see in children with these neurometabolic disorders, commonly seen in children now. This is a child, usually they present around toddler age group or early childhood with developmental delay and artistic feature. Artistic features means usually they will not be interested in communication and language, so they'll be preoccupied in their own activities. This is a common presentation, and again, the family, they're married in relatives, and birth history was normal. So an examination head size was small, and hair of the baby was low color, hypopigmented hair, and again, this child is an artistic feature example. This is a photograph. You can see the child head size is small and changes are brownish, and this child, you can see she is preoccupied in same repetitive activities, that is suggestive of autism. So this is a characteristic phenotype. Usually we'll see with phenylketonuria. This is one of the commonest neurometabolic disorder, and it was confirmed by the simple baseline test like TMS. Again, it is shown phenylalanine level was very high. So suggestive phenylketonuria. So these are a few more families affected by multiple members because it was not diagnosed early. These are families, many members are affected. So you can see all children at small age, they're not very bright and they're dull looking, and hair color is very hypopigmented, suggestive of phenylketonuria. And this is a family, you can see that 3 siblings are affected. What is the importance of diagnosis early is, this is a slide is shown. This is the first child, second and third child. This third child is diagnosed very late, around 7-8 years. The second child diagnosed very early, like 3 or 4 years. That the third child diagnosed in day 1 of life with screening. So child started treatment, this third child on day 1 of life. The child is perfectly normal. The second child started very late, but the outcome is better than the first child. First child is started very late because diagnosis also made very late, so outcome is very bad. So that this is a slide that shows that you should diagnose these disorders very early to get the proper response. So whenever suspected these children, it should be confirmed and the treatment should be started. This is a flow chart. It shows that whenever the phenylalanine is increased in the blood, there are many disorders that can mimic not only phenylketonuria, some other disorders also can be mistaken for phenylketonuria. These are some of the examples where these children will be more abnormal compared to phenylketonuria. These children are severe neurological manifestation, like in this child showing dystonia. These children also, they will improve with the treatment. Child has significantly improved after starting the treatment. And this children again mimic like a phenylketonuria, but treatment approach is different. This is one more group of disorder where phenylalanine can be increased in the blood level. This is DHPR deficiency. Again, these children will be treated with some other disorder like epilepsy and other things, but child has not improved. But after starting specific treatment, child has significantly improved with dietary modification and some simple vitamins. Child started walking and running also within a few days of starting the treatment. And again, the same group of disorder. This child also treated earlier as an encephalitis, that is brain fever, but there was no significant improvement and there was worsening was noticed. So after starting treatment, child has improved significantly. The same child now around 4 or 5 years, child is almost able to walk and able to speak. But earlier days, child was bedridden only for many days. So these are the other group of disorders that can present to phenylketonuria, but they have different etiologies. So subcategory of this increased phenylalanine categorization is very important. The treatment approach is different. The other common group of disorder is homocystinuria. Usually in adults, usually they present the stroke, common presentation, but in children they present the intellectual disability and also high myopia. Usually they have lens subluxation and dislocation causing they require a high power and the glasses are very thick and they have problem in seeing long distance. So these children will present with intellectual disability. They can also present with stroke. This is a child presented to ICU with a stroke because of clot in the brain, and child has survived with treatment and child almost become normal except with a few learning problems. This is a group of disorder where homocysteine is a metabolic problem, where homocysteine level will be elevated compared to previous children showing phenylalanine was elevated. So in these children, homocysteine level was elevated. So that is a biomarker that you can detect in the blood and you can assess, and also you can target the treatment. Other way of presenting this homocysteine metabolic disorder, they can present autism again or also intellectual disability, and they can, this is a child showing refractory seizure. The child never responded with any of the medication that are available with current treatment for epilepsy. This child requires specific treatment for homocystinuria. And again, these children can present with the West syndrome, what we call. So again, this disorder should be considered whenever child coming with epileptic spasm, what we call West syndrome, and it should be recognized. So appropriate treatment gives better result. Some of the other conditions, like a nutritional condition, can also produce hyperhomocystinemia, that is increased homocysteine, resembling the metabolic disorders. But these children will be having severe nutrition deficiency because of B12 deficiency that is commonly seen in vegetarian mothers, those who are feeding exclusive breastfeeding. You can see along with this problem, children also, the hair color is low, and also there you can see the hyperpigmentation of knuckles. That is suggestive of B12 deficiency. In these children, homocysteine again it will be high, but in these children the improvement will be very fast. It's just supplementation. It's a regular vitamin B12 level that can mimic like neurometabolic disorder like glutaric acid. So it should also be considered. They can also present a stroke-like thing because of B12 deficiency. This child showing the weakness in the left side of the body. Child has significantly improved with treatment. So hyperhomocystinemia can be there in nutritional B12 deficiency also in addition to metabolic condition. So whenever there is an increased homocysteine level in the blood, you should consider many disorders. So not only the metabolic, nutritional, some of the transport defect also can present increased homocysteine level. And regarding the management of increased homocysteine, diet restrictions there, like methionine containing food should be avoided. You should monitor the vitamin B12 and also monitor homocysteine level. And you should try with these high doses of vitamin like pyridoxine, folic acid, B12 level, and betaine. These are medicine currently available to decrease the homocysteine level and also to improve the cognition of the child and also prevent the strokes in the children. This is a flow chart. I'm not going to detail. So whenever a child presents with the increased homocysteine level, so this is the approach so that you can analyze step by step and you can come to a conclusion there is a problem in the child causing increased homocysteine and they should be treated appropriately. Next group of disorder is the urosacral disorder. These children also again present with classical neurometabolic disorders. There are many subcategories in this again. So I'll be giving some of the examples. Here a case scenario, one child come with a 5 years old child. Usually this is a common presentation to the neurology OPD. This child presented a developmental delay and again born to a consanguineous parent with a normal birth history, and child presented with stiffness of the limbs and also the swaying of the body when child is walking. And this you can see the stiffness of the limbs. The limbs are really stiff, and MRI showing the atrophy of the brain. The brain size is sunken, especially cerebellum of the brain. And a simple blood test like TMS gives increased alanine level in the TMS. That is arginine is suggested for arginine deficiency and confirmed by genetic testing also. So early diagnosis is important. That previous child you can see child was grossly abnormal. This child diagnosed again in the newborn period, child has a good improvement and able to walk. But this child diagnosed very late, you can see the severe spasticity, baby with bedridden, not able to walk. The few more children diagnosed very late, they're all bedridden and non-ambulatory. So that is the importance of diagnosing these children very early and starting the treatment. These children again not only present with the cerebral palsy like intellectual disability, sometimes they can present readily with the encephalopathy with because of raised ammonia level. So next group of disorder in this subcategory is usually they will present with, in the first few days or months of life with seizures, coma, and refugial fits. And the examination usually it will be lethargy and comatose, and some blood tests that commonly done blood test in metabolic disorder ammonia, it will be elevated in most of these subgroup of disorders. And as usual, this child ammonia was very high, 400. And some subtle features and exam like abnormal hair splitting that gives sometimes a clue for this group of disorder. MRI also gives some clue of suspecting these disorders, showing again atrophy of the brain and signal changes and confirmed by genetic testing. So again, these children will improve with special diet formula and also treatment for hyperammonia. Children, you can see from newborn period, they are following up to 10 years, there is significant improvement in the development as noted. Again, one more type of presentation is, again, these disorders also can present with recurrent encephalopathy. Usually brain fever comes once in a time, but it will not come again and again. But this metabolic condition, if a child again goes for coma second time, you should always consider this metabolic condition rather than brain fever. And they can also present with a stroke. If child is coming with a stroke 2 or 3 times, you should consider the metabolic stroke. And also recurrent encephalopathy, recurrent brain fever-like thing they can present. This child presented the recurrent episodes of stroke and also recurrent comatose comatose episode. So this child, on investigation again showing ammonia was very high and alkalosis was positive. Infection workup like brain fever workup was negative. This child, you can see the weakness of the limb, and after treatment there was improvement is there. And this MRI shows that the stroke-like thing in the MRI of the brain. So most of the times you'll consider stroke and you'll start treating and investigating for stroke, but you may not get yield of any positive results. So you should always suspect metabolic cause of the stroke whenever the stroke associated with encephalopathy like comatose children. And this was confirmed and child has significantly improved. Again, the other way of presenting this child, again, like an encephalitis, like a brain fever, they can be mistaken for brain fever. You should always consider a metabolic condition. If there is no significant improvement and phase of examination will be normal, usually in this metabolic condition. So they are not very rare group of disorders. We will see more than 50 children in this group of disorder. Most of them can be diagnosed nowadays because improvement in the diagnostic facility like metabolic test or genetic test, and some of them are treatable with specific formula and diet and can be prevented with diagnosis in the antenatal period for their parents in the next pregnancy. This is a flowchart just showing whenever there is an increased ammonia, you should consider subtypes, and you should investigate appropriately, and you should do a specific diagnosis. And there is a high ammonia. This is a flow chart that shows how to flow. Next, how to subcategorize this ureterical disorder. They require further testing like urinary uric acid assessment and also genetic tests sometimes. So the treatment of this disorder, basically they present with you early in the life, and with present in the ICU. They may require dialysis like peritoneal dialysis or hemodialysis to remove the toxins of the body like ammonia. And they require low protein diet. Usually high protein diet should be avoided, especially during sick period. And there's some of the medicine like sodium benzoate is available to treat the increased ammonia level. So after that, I can go to a normal diet with the low protein diet that is useful. During the episode of hyperammonia, you need to avoid high protein diet and also require sometimes medicine like sodium benzoate or ginine also. This is a flow chart. So how to go about when child has a suspected this ureterical disorder. And this is a chart showing how to treat ammonia if level is very high in the body. So based on degree of ammonia level, you should plan which treatment should be considered. So to conclude, these metabolic disorders are, even though they are rare individually, but if you combine everything, they are not very common. And the most common disorders are already described as phenylalanine homocysteine ammonia disorder are common. These tests are easily available. Whenever if you are doing tests, these tests should be considered, and I should be appropriately, you should investigate where is the reason for these conditions. And if still doubt, you should go for a genetic testing, because the treatment of subcategory of disorder is different and outcome also different, and also genetic tests should be considered to confirm the diagnosis, and also counseling is required for these children. Thank you.
Thank you so much, Dr. Raju. So, sir, my first question is, how do you approach the transition of care from pediatric to adult services for patients with chronic neurometabolic disorders?
Yeah, whenever you are practicing a multi-specialty aspect, it is good only. So you should always smooth transit. You should coordination with adult persons like adult physician or adult neurologist. You should inform about the disease, nature of the disease, what medication they are on, and all the file details should be kept ready. And I should tell that what child is on currently, what's the appropriate treatment child is required, how to manage. So because adult physician may not be aware of childhood neurometabolic disorder, so everything should be kept ready, and they were transferring better before only. You should discuss with family, child, and also physician, so that they'll be aware. And sometimes they may require 2-3 times again to visit to pediatric people before establishing the adult people. So it is over a period of months, sometimes years also. It cannot be transferred over a period of one day because it's a long process.
So we'll take the second question now.
Yeah.
What are the potential long-term complications or comorbidities associated with these disorders, and how do you address them in your treatment approach?
Yeah, most common is usually these children will be having some intellectual disability. Intellectual disability earlier used to call mental retardation. They'll be having difficulty in understanding day-to-day activities. Initially, they may have delay in walking, speaking, all those problems, and especially they're coming to learning. There'll be a lot of problem. They need to take many days holidays. They're not able to cope with studies. They are learning problems. And some behavioral problem, like they'll be very hyperactive and the concentration is the problem, and they can have physical growth problem also. The growth of these children will be less compared to normal children. So all these psychological problems will be there. And sometimes whenever they get infection, the chance of going to coma and deterioration, rapid deterioration is high. So these are some of the complications usually they'll face.
So how do you support families in coping with these challenges associated with these disorders? Also, do you have any recommendations for resources or support groups they can access?
Yeah, so I thought there are many subgroups in this neurometabolic disorder. Each disease has some organization. In general, organization for rare disorder is available. They can approach this group in India, and And basically, you need to give some idea about because the treatment specialist for these disorders is less. So you should refer to a specific center, those which are experienced in this disorders. You should give some idea of contact details. And also some of the medicine available, not easily available for these disorders. So we need to give some details about where exactly the medicine available. Especially these formula diets may not be available easily. So sometimes it could be imported also. So you should give idea about where they will get these medicine and where they should get help. So only few centers are available. Especially going to peripheries, it is difficult. Only it will be available in some of the metro cities, and district level it is difficult sometimes.
So one last question.
Yeah.
So in your experience, what are the most important considerations or factors that contribute to the success of these long-term management for treating neurometabolic disorders in children?
Yeah, one of the most important factor is early diagnosis. In most of the developed countries, there is a screening program, what you call newborn screening program. So they will do universally all children, irrespective of what is the where they are coming. They need to do all children, those who are born within 72 hours of life, they should undergo this test. So before the disease onset, they will diagnose these disorders. So that if you diagnose early, if you start treatment before they manifest, they usually have a normal lifespan. But in India, that program currently is not available because the population size is high and cost may be prohibitive. But that is one of the best things that can be done. So that early diagnosis is very important. So once the onset of the disease sets, they usually, even though if we treat, the outcome will not be 100% normal. So there will be some amount of problem, but at least diagnosis should be made. The other problem is diagnosis. Earlier days, we used to face a lot of problem, diagnostic workup, like investigation not easily available. And they are very expensive also. So some of the poor patients may not be affordable for these tests. And availability also is the issue. And awareness of the doctors also less because these are rare disorders. They may not see commonly. And coming to the treatment options also, some of them are treatable, not all conditions. So even though some of them treatment options, the availability of medication also a lot of problems. It may not be available easily. And you may need to struggle to get the proper medicines also. These are some of the challenges we'll face with these disorders.
Sure, sir. Thank you so much.
Thank you.
And thank you so much for answering all the questions, sir. If we receive more questions from the audience, we'll get back to you. It was wonderful having you with us on Doplexes. And we'll close today's session. Thank you so much.
Thank you.
Dear audience, thank you so much for tuning in, and keep watching Doplexes webinars. If you have any recommendations, please write to us, and we would be back with yet another clinically rich discussion exclusively on Doplexes. Until then, please take care. Have a great evening. Thank you so much, sir. Thank you so much.
Thank you.